I'd like to spend the majority of the time talking about treatment planning, since that's the bulk of this lecture. So this was just kind of a review of what we talked about last time in regards to screening and assessment, that this really is a necessary step, the screening piece, for any clinicians working with the substance use population. And thinking about using your screening methods to help develop episodes of care. So rather than thinking about treatment as going from sort of someone is really problematic or presents with a serious set of consequences, then they enter treatment, and as soon as treatment's completed, then you don't see them again until a relapse. Thinking about that a little differently, recognizing that substance use disorders, opiate use disorder, is a chronic condition, that we really need to have sort of a series of treatments, and that those can step up or step down depending on the level of intensity that a patient needs. And episodes can either be consecutive, so one right after the other, or they can overlap. So somebody's episode with their psychiatrist is one versus with their therapist versus with their peer support. And so that's why it's important that we really have clear shared treatment plans that help us to guide that continuum of care for the patient. So thinking about a treatment plan as sort of the living document, multi-user document that follows the patient, rather than sort of that administrative checklist that, that we have to do for a regulatory body. It really can be an extremely effective tool that guides all of those different episodes of care and helps to determine what's next for the patient, who is this patient, and sort of the really important things that need to follow them. Again, I'm gonna move through. Anyone who's not familiar with ASAM, please reach out to us. We are an ASAM state. It is one of the recommended models to be able to assess patients and make some of those treatment recommendations across the continuum of care, from sort of an acute detox state to an outpatient state. It assesses on 6 different dimensions and 3 different levels of severity. And so it's a really good tool, which has really good validity to help us level a patient. So essentially, what is the type of treatment that they need right now? That information, whether you're using ASAM or not, would be recorded in a treatment plan. So what is a treatment plan? Well, it's a written tool that helps to shape and focus treatment. It is probably one of the key elements in driving effective treatment. And every single client should have one, and every client that you work with, you should know and be familiar with their treatment plan. All treatment plans or effective treatment plans include the following components. You need to have a definition of the problem or problems that are identified in your screening and assessment procedures, the treatment that's being prescribed by all of the providers and all of the different episodes of care that the patient is engaged in, the timeline for those treatments, and a way of noting progress, the major treatment goals that address those problems. You need to have a section where you address strengths and barriers, not just progress, but sort of like overall the strengths and barriers that are going to follow this patient. So why are they so important? Because we know every major regulatory body requires one. So what is that really about? Well, we know, based on the evidence, that when we stick to a treatment plan, we don't get off course. It really helps patients in following through, in us following through. It helps to reduce all kinds of risk, fraud, waste, and really unintentional harm because we get stuck, because we're not sort of tracking where the treatment is going. It will also increase the likelihood that a patient is going to receive necessary services, because when you sit down to create a treatment plan with a patient, or you're looking at one and you're contributing to one, you're really looking at the whole continuum of care, and you're able to see the gaps. You're able to see the things that the patient is missing. So if you think about it, this is really our flight plan. So just like when we get in an airplane, we know that the pilot has filed that flight plan, that they know exactly where they're going to go, how long it's going to take, and what's needed to get there. We put our trust in that. And so our patients do the same thing for us, right? That we wouldn't want to get on a plane and we don't know where it's going to go or how long it's going to take. Patients trust us that when they come to see us, that we have that same kind of direction. It's also important to have a treatment plan in the sense that if something does have to change, that needs to be documented in a way that all the other treating providers can access that information and that the patient can access that information. So if something does have to shift mid-air, then at least you knew exactly where you were going and you know kind of what has to adjust or what needs to get off. And you're not doing things in isolation. Because if we don't have this plan in place, we are likely not going to end up where we intended. And unfortunately, that does tend to result in patients leaving treatment before they really should. And that's one of the outcomes that we're all trying to avoid. We want to keep patients engaged in the right level of care for as long as they need to be in that level of care so that they can maintain their functionality and stability. One thing to know about treatment plans is they're going to be more effective if they're integrated. So that means that it's a multi-user document. As a provider, you absolutely should have your own treatment plan for the work you're doing with all of your individual patients. But the research proven model that's adopted by multiple regulatory bodies is and especially endorsed like by institutions like NIDA and SAMHSA, is that individuals with substance use disorder tend to have other comorbid psychiatric conditions or severe mental illness. So they tend to be some of the more complicated patients that we work with. And they most likely are going to need what's called integrated treatment, so multiple service providers. So the gold standard is really making sure that either we have like an ASAP where we're an integrated team, we have multiple providers that might touch that patient. All of us will contribute to that treatment plan and have shared treatment goals. If they have a provider out in the community, it is part of our responsibility to reach out and coordinate care with some of those providers and make sure that that treatment plan is shared as effectively as possible so that we're attending to all of the different domains that might be impacting that person's ability to remain functional. So it's really, really important that we think about it as kind of like a team treatment plan rather than just a provider treatment plan. Most organizations will aim for this, but it's really hard to actually fulfill it. I think that there does tend to need to be some solid support by leadership or administration in your agency to make sure that there is time and support set aside for these integrated plans to be developed and worked on, because it should be really multifaceted, and that does take some time to make sure that it's useful and it's not just a kind of check the box document. It should also be accessed regularly. So if this is one of those things that you're only looking at maybe once every 90 days, maybe even less frequently than that, then it's probably worth reviewing. Does something need to change with this plan, or does something need to change with my clinic workflow? Because if I'm not accessing it as part of routine care every time I see that patient, then I'm probably not using it the way it was meant to be used. It should also be behaviorally specific and have achievable goals written. So not these vague kind of long-term, I want to stay sober kind of goals, right? That it really needs to be behaviorally specific and measurable so that we can track progress, we can encourage progress, and we can note on progress when it happens. It should also be developed collaboratively with the patient. So this can be a really fun way of structuring a session, is pulling out the treatment plan and kind of walking through sort of what does it look like and is it meaningful to them? Because really this is their document. And so it should be discussed with them regularly, and they should be able to add to it, know what's in it, kind of share ownership of it. It should also be the primary vehicle used for any team staffing discussions or communications about the patient. So a solid treatment plan is going to have a section for team discussions team evaluations, any notable changes or things that the team needs to act on, and then who's assigned to follow up. That should all live in the treatment plan, because that's one of the best ways to have a one-stop shop for all the information that's going to be affecting the course of treatment for that patient. So here are some general concepts that go into developing a really strong treatment plan. One is recognizing that recovery is more than just symptom remission or stabilization, that recovery involves the development of new meaning and purpose in someone's life. And so a good treatment plan isn't just going to have things like decrease use. It's going to also note on work and interpersonal stability and connection and leisure and enjoyable activities and all of these different domains of life, because those are the things that actually denote recovery, not just absence of use. It's also going to include the client pretty significantly. If they don't own the plan, they don't know about it, and they don't know what's in it, it's probably not a very effective treatment plan. That in order for them to act on the goals that have been set, they need to know what they are, and they need to buy into them. They need to know that those are meaningful goals for them at this point in their life. There's also a difference between multidisciplinary and interdisciplinary treatment teams and plans. And what we're really trying to aim for is not just, you know, the PCP has a plan, the dentist has a plan, the prescriber has a plan, the counselor has a plan. That's multidisciplinary, that's great. But if they're not sharing one plan or talking to each other, then it's not interdisciplinary. And that's really the gold standard that we're trying to aim for. So we don't want people just doing their separate jobs. We really want them to do those perspectives and jobs and bring them together, bring them on the table so that you can have a shared formulation and a shared approach. The treatment plan should be reviewed or should be viewed as fundamental to the treatment process and not independent of that process. And there's an expectation that teams will use the plan as part of their clinical encounters or the interventions that they provide. So in addition to your normal charting, you should look at the treatment plan. Maybe there's information that you need to put in there. So if you think about this as really the primary vehicle or one of the primary vehicles that can be used to help patients engage in their own care. So it says that people must take significant responsibility for their own recovery by being an active participant in their own rehabilitation. Treatment planning is fundamental to this process. So again, it's one of the main ways that we can engage. We can use our good motivational skills. We can have a very explicit and regular conversation about their treatment goals. Then they are much more likely to actually follow through on that goals. It's kind of amazing. When we talk to people about what the next steps are, they're a lot more likely to do it than if we keep it a mystery. So there are 3 parts that are required in good treatment planning. One is the treatment team structure. So how does the team operate and utilize the plan? What is actually in the plan, so the content of it, and then the planning process. How is it developed and used? So for team structure, this includes 2 different teams, the core team and the extended team. The core team is anyone in your agency that is the primary treating providers working with the client. And then the extended team includes people outside of your agency, community providers, and anyone involved in the client's care. So concerned significant others can also be brought in as extended members of the treatment team. The team should have an identifiable structure. So there should be some kind of a lead who's responsible for that treatment plan. And then various people can have flexible roles in terms of how they contribute to it or access it. Content for treatment planning needs to include the following things: any primary assessments that are completed, the diagnosis and problems of record that are current and active, a brief formulation or summary, discharge criteria and aftercare plan. So what is going to be needed for this person to have long-term recovery for self-guided work? So basically, if it doesn't look like what's on the aftercare plan, then the person isn't ready to be discharged. So we need to kind of know where we want to go at the end of all this, and that's what we're working towards. Needs to have long-term goals and short-term goals identified, and then specific interventions that are linked to each one of those goals. And then lastly, we want every treatment plan to include a crisis or safety plan. So the plan that the patient fills out and updates regularly that they use for any acute crises. The best way to do short-term and long-term goals, but definitely short-term goals, is using the SMART model. So that means making sure that the goal is specific, measurable, attainable, and results-oriented and timely. So that should include some kind of a goal statement, which can be in the patient's own words. I don't want to use drugs anymore. A measurable objective. So how do I break that into something that is SMART, that is specific, measurable, attainable, results-oriented, and timely? And then what's the intervention that's going to help me to achieve that measurable objective? And then how do I comment, how do I measure and comment on progress, right? So here are some goal examples of goal statements, right? So it needs to be behavioral and measurable. So client will be able to function independently. That's an example. How do I want, versus like, I want to find stable housing. So thinking about the language that you're using to describe this, it could be bigger in terms of like sort of that long-term goal. But we really want to tighten it up when you get to the objectives. So this is where you want it to be realistic. So identifying the objectives, the what, why, and when. And then make sure that every goal statement has a specific treatment intervention linked to it. And you also need to note the type, mode, and frequency of contact that's recommended. And then be able to list how was it the progress? How was it accomplished? When? What was accomplished? Are there any additional interventions or services or follow-up needed? In terms of discontinuing objectives, we only want to do that when the client states, I'm just not ready to work on this yet, so I'm putting it on pause. It hasn't been achieved or it was accomplished, and we want to note that and exactly how. So this is the overall treatment planning process for how we would move through it. You have an initial plan, which is sort of following that initial intake assessment or initial H&P, where you have the initial formulation. Then as the different people that work with that patient meet and the team starts to form, then that all becomes sort of flushed out and you get the complete treatment plan. And then you need to use it for ongoing care. So it should really be the foundational document that follows all clinical encounters, regardless of who is working with that patient. Everybody should be checking in on that treatment plan. Okay, so that was a really rushed, quick and dirty version of this lecture.